I'd like to introduce our speaker, Dr. Stephen Radke. Dr. Radke is a minimally invasive gynecologic surgeon at Norton Urogynecology Center. He earned his medical degree in Monterrey, Mexico, and completed his OBGYN residency at Southern Illinois University School of Medicine in Springfield. Dr. Radke completed a fellowship in minimally invasive gynecologic surgery at the University of Tennessee College of Medicine in Chattanooga, where he trained in advanced laparoscopic and robotic surgery, specializing in complex pathology such as severe endometriosis, chronic pelvic pain, pelvic organ prolapse, large uterine fibroids, fertility surgery, and mesh removal. Welcome, Dr. Radke.
All right, thank you so much for that kind introduction. Let me just share my screen here. All right, perfect. I think...
It looks good.
All right, perfect. I always have to verify that before we move on. Okay, so we're going to talk about uterine fibroids, and the word demystifying is it just comes from the fact that sometimes this is a diagnosis that is encountered very often, and there can be a lot of questions regarding what it means to find the fibroid and what the clinical implications are, because there's a huge variation in how this presents and what needs to be done. So that's hopefully after today we can clarify a little bit of that and some of the treatment approaches and diagnostic approaches as well to this problem. No financial disclosures. So as far as objectives go, I wanted to just give a brief introduction in general about some key topics and high-yield information pertaining to uterine fibroids before moving on to a couple of cases that literally we just saw in the last few months. I think there's not a day that goes by in our clinic that we're not seeing patients with fibroids or complex fibroid issues. So I just chose two that were a little bit peculiar, and we'll go over those. But like I said, I just wanted to go over a few generalities, which I think can be helpful for everybody. So first of all, what are fibroids or uterine leiomyomas? And essentially, these are tumors. They're neoplasms. They're not cysts. That's something that sometimes there's that confusion from patients and occasionally from providers that there's some question about the composition of this. So these are hard neoplasms. If we when I'm trying to cut into them or doing surgery or whatnot, sometimes we'll have to go through multiple scalpels because they'll lose the scalpel will lose its edge because of these things being so dense and so hard. So these are hard neoplasms, and they're composed mainly of smooth muscle and fibroblasts with a very dense extracellular fibrinous matrix. We know that they are monoclonal neoplasms. There is one progenitor cell that undergoes a mutation. It can be a chromosomal deletion, translocation. There's multiple kinds of mutations that end up in fibroids. And then from there on, that cell just keeps multiplying, and creates these masses that arise from the uterine smooth muscle. And there's a wide spectrum of smooth muscle tumors. When we say leiomyoma or fibroid, that is just one element in the long spectrum. And as you can see, I kind of put them in this little table here. At the very left, you see leiomyoma or fibroid. That's just a benign, smooth muscle tumor. They're very common. You see them. But there's just an element in a spectrum. And at the other end of the spectrum, we have a leiomyosarcoma, which is, aggressive smooth muscle cancer. And everything in between, right? So what differentiates one end of the spectrum from another, at the end of the day, all it is going to be how these things look like under the microscope based on the presence or absence of coagulative necrosis or number of mitoses per high power field or atypia. Based on that, the number of mitoses, the degree of atypia, or the degree of necrosis is how the pathologists classify where somebody lands in the spectrum. And this is important because, of course, there's huge differences and implications and follow-up and management based on what we find. Fibroids in general, when we look at that left end of the spectrum, very common problem. And I actually say problem, I want to say that in quotation marks, because over 70% of patients will, if you scan everybody, just take 100 people randomly and scan them at the age of 45, 50, you'll find that about 70% will have fibroids. one or two, maybe small ones, but you'll find some on ultrasound or something. So technically, you can say that it's more normal to have fibroids than not have fibroids. So people will have them. Because of that, prevalence is age dependent. That's why when I was giving that previous example, I said 45 to 50. But if we take 17-year-olds, we're not going to find fibroids because they develop, obviously, as people go through life, there's more opportunity time frame for those monoclonal neoplasms to form because of deletions, translocations, etc. So the more advanced in age somebody is, or closer to menopause, the higher the chance you'll find them. We know for a fact there's a huge genetic predisposition and race predisposition to fibroids. That's been very clear in the evidence and when we do large epidemiology studies on these things. It definitely runs in families. We do see if somebody has a first-degree relative that had a lot of fibroid tumors, chances are that person is going to have not only fibroids, but symptomatic large fibroids that are large enough to cause a problem. We don't have a single mutation that we can identify genetically to say, oh yeah, your risk of fibroids is, we don't have that yet. But we do know that it runs in families. Race is actually a big factor. Black women tend to experience fibroids and symptomatic fibroids at a significantly higher rate. Prevalence in Black women tends to be over 80%, 80, 85%, but not only that, the fibroids tend to be larger and hence more symptomatic. There's also known environmental factors that can predispose people to developing or not developing fibroids. For instance, one of the biggest things that we know is pregnancy. People who have had pregnancies are much less likely later in life to develop large symptomatic fibroids. Likewise, if somebody's been exposed to birth control, whether it's combined oral contraceptives or Depo-Provera shots or whatnot, their risk of developing fibroids or large symptomatic fibroids later in life is less. And why is this? Well, we think that it's the exposure to progesterone, basically. The exposure to progesterone might have some effect on the myometrial, or we know it has an effect on myometrial cells, and might quell the development of these mutations, again, due to maybe reduced division of cell division and such. But pregnancy, that's why pregnancy explains this as well. Of course, when people are pregnant, they're exposed to an astronomical dose of progesterone produced by the placenta. So there's that. Of course, on the other opposite side, nulliparity is a huge risk factor for developing large fibroids later in life. So those are like the main risks that we see. In general, like I mentioned, it is a very common problem. It's the most common benign gynecologic neoplasm, most common benign gynecologic neoplasm. And from a financial standpoint, just in direct medical costs, it's over $5 billion a year to take care of patients for fibroids specifically, whether it's with surgery, ER visits, medications, blood transfusions. It amounts to being over $5 billion annually spent on this in the United States. But then if you look at indirect costs like disability, absenteeism, etc., it amounts to over $15 billion. So it's a huge has a huge economic impact as well. So like I mentioned earlier, fibroids are very common. I mean, 70%, 80% of people might have them. However, what we really care about is when do they start causing issues? When do they start causing problems for the patient? When do they start causing anemia, et cetera, that kind of stuff. And what we know is that in general, out of all people that have fibroids, only 25% or a quarter will have symptoms. And there is a huge variation in the spectrum of symptoms that people can experience. And that's why sometimes with these things, diagnosis might be delayed because somebody might present with a certain type of symptom that you're not suspecting a fibroid and search through a different rabbit hole and eventually they're found with imaging. But again, the reason is because there's a huge variation in the spectrum of presentation. And the two biggest variables that will determine what makes a fibroid cause symptoms or not, or what kind of symptoms a patient will experience, are location of the fibroids and size. And as far as the gamut of symptoms, you can have anything from bleeding, pain, bulk symptoms, which might be different than pain. Some patients present as just feeling like a heaviness in the pelvis, or they feel like there's something that's weighing them down there, not necessarily pain, just like what we call bulk symptoms. Some people present with urinary symptoms. If there's something pressing against the bladder, that's urinary frequency, and they have 5, 10 urine cultures before getting imaging, and it was a fibroid all along. Infertility is another thing, and we'll talk a little bit more specific in the coming slides, but that's another aspect. So location, just to clarify a little bit what we mean by location. This here is one of the classifications that we just use for communication purposes, and we classify fibroids from type 0 to type 8. And essentially, it just goes from 0 being something that's completely inside of the cavity, like pedunculated, like as you can see here, the 0. And then as it moves deeper into the myometrium, it goes 1, 2, 3, 4, 5, until 8, which it can be a cervical, so it's no longer part of the uterus, or 8 can also be what we call a parasitic fibroid, which means that it was a fibroid that maybe was a 7, so almost like hanging off by a thread from the uterus, but then detached and attached somewhere else to the intestines or something, and so that's also a class 8. But as you can obviously see, like depending on where the fibroids are located, there will be a huge variation in symptoms. For instance, people that have a fibroid that is a type 4, that is well embedded here, like within the muscle, and it's small, probably it's just there. People are never going to notice. It's not going to cause any problems. However, if you have like a large fibroid inside of the uterine cavity, well, you'll certainly start having symptoms from, probably pain and bleeding. And that comes from the fact that the uterus identifies that there's a mass there that needs to come out, and reflexively it tries to contract to extract this mass, but it can't. The mass is attached there. But that contractility and chronically trying to contract this mass out will result in chronic pelvic pain and pretty severe dysmenorrhea as well when you add a menstrual cycle. Likewise, as far as when we talk about bleeding, because of how the fibroids affect contractility of the uterus, the uterus usually, when somebody's undergoing a menstrual cycle, contracts, and that's what closes off all the little blood vessels, during menstruation and as it's shedding the endometrium. Contractility of the myometrium is what actually closes those little blood vessels to stop the blood flow. However, if you have a large mass wedged in there in the muscle, well, that contractility is going to be impaired. So those little blood vessels will remain open for longer, or just chronically remain open and just continue to bleed. So as you can see, again, location is really, really important. Likewise, if it's close to the bladder, you'll have bladder symptoms, etc. So there's that. Now, sometimes we talk about submucosal, intramural, and subserosal fibroids, and that's just basically breaking down submucosal, anything that touches the inside of the uterus. Subserosal, anything that's kind of like bulging towards the outside. Important to differentiate, though, because treatment options will vary significantly, or the options that we can offer patients will vary significantly depending on where these things are located. And again, as you will see when we review the cases, size is the other factor. So you can have, this is just a view of somebody that was having like a tubal ligation, no symptoms from a fibroid, but there you can see it in white, a tiny little bulge there, almost just looks like a pimple almost. That's just a tiny little fibroid that's just there. It's not causing any issues, not any symptoms. It's just there. So there's that. Or you can have something like this where literally you can't even see the uterus. It's just a huge mass that's occupying almost the entire pelvis and abdomen. But again, so there's a huge spectrum in what you can see, and obviously the symptoms will be different depending on that, right? One of the things when we look at the cases and we have people that present and we suspect fibroids, we always have to keep in mind what our primary goal is. And I know this might sound, kind of pretty obvious, but it's very important to keep in mind that the goal at the end of the day is improve the patient's quality of life based on what that patient is trying to achieve. Some patients' quality of life might look like getting pregnant in the next 3 months or the next 6 months or whatever. That might be what they're looking for. Or their quality of life might just be reducing the pain or reducing bleeding or maybe reducing blood symptoms or urinary symptoms. So keep that in mind. What is the patient trying to achieve? Because that will alter what options we offer the patients. Every treatment targets different things. So we got to make sure what goal we're trying to address. Improved physiologic parameters should be another goal. If somebody is severely anemic, which a lot of patients with bad large fibroids that have bleeding as a symptom will come with hemoglobins of 5, 4, 6, that kind of stuff. And certainly that will have an impact on their entire life and other organs in the body. So improving those physiologic parameters is also something to keep in mind. And then, of course, we always want to ensure that whatever we're seeing, a tumoration, an ultrasound, or whatnot, well, we want to ensure that we're not dealing with a malignancy, because that has another whole array of implications that put patients' life at risk on a short term, honestly. Some of these tumors can be very aggressive. So those are the three things we want to kind of keep in mind whenever we see somebody for fibroids or we find the fibroid. So I would say it's always important to ask the patients, what is it that you want to achieve? Again, these sound like really obvious things, but everybody's goals are a little bit different, and keeping that at the forefront is important. The pregnancy question, extremely important as well, because again, there's as you will see here in a bit, there's a wide array of treatment options, but what you choose will depend a lot on what their desires for fertility are in the future, what their plans are, how long do they want to wait, that kind of stuff. So things to keep in mind. So one of the things that a lot of people encounter, especially in the primary care setting, is what do you do with these incidental asymptomatic fibroids? Say somebody had a CT scan because of the abdomen and pelvis because you were suspecting gallstones or something, something like that. But then on imaging, there is a 3-centimeter fibroid or a 2-centimeter fibroid that is reported by the radiologist, or such. So what do you do with that? So most people can do, okay, referral to OB/GYN, which is appropriate to get a second opinion, but it's good to kind of like know what is out there, what is done for these. Are they always necessary to follow? And in general, we usually recommend to use clinical judgment. So obviously, if you find something like this, it's important to maybe do a little bit more questioning. Okay, do you have symptoms from this, or pain, bleeding, anything like that? If there has been previous imaging done in the past, a lot of patients, if you look back, especially now with electronic medical records, it's really easy to see things that have been done 5 years ago or 6 years ago. Within seconds, you can get that information. So you can always compare if it's new or this is not new. But always keeping in mind that, like we mentioned earlier, 70% of patients will have fibroids. So it's not an uncommon thing, right? Sometimes when we tell patients that we're referring you because we found a tumor in your uterus, we're referring you to a specialist or OB/GYN or whatnot. The first thing that patient starts thinking is, okay, I have cancer. So a little bit of this information is good to reassure the patient of, it's a common thing. We just want to make sure that it's not something that needs to be followed up on or whatnot. In general, when we say that followed up on, serial imaging, when we find the fibroid, is not supported by evidence. There's been studies that look at this and see, okay, if we take patients that we just found incidental fibroids and we just say, okay, let's follow up in a year and see what happens. Studies that have been done on this don't really find any difference. Like, fibroids usually don't, and the majority of patients are not going to change that much to cause, to make an impact. Most of the time, when we decided to do something different, whether it's more imaging or a treatment, is when patients develop, it's symptom-based, when patients develop symptoms. That being said, I mean, of course, there can be that weird situation where you have a patient, you find a 3-centimeter fibroid, and you say, okay, let's come back. It just looks like a fibroid. Let's come back in 6 months and reevaluate. And then it's suddenly this necrotic 8-centimeter malignant-looking mass. Well, of course, in that situation, you'd be like, oh, I'm glad I did this. But the problem is that is that would be a very rare, occurrence. In general, masses that look like fibroids, the chances of them being a cancer, like a leiomyosarcoma, in general, we say that it's less than 1 in 500. So, in general, because of that, when we do studies, of course, it's not going to show, a difference that serial imaging is going to be helpful. In our practice, we don't usually do serial imaging unless, the fibroid is kind of like of a significant size, maybe like 4 or 5 centimeters, and it's the first time that we see it, and especially if the patient's a little bit like older, like 40, 50, and we usually just have patients come back in 6 to 8 months. again, not an evidence base. It's just going to be very difficult to find evidence to prove that that small amount of patients or that particular population will, that will result in a difference. But again, clinical judgment is key to make these determinations. But in general, bottom line, 2 centimeter, 3 centimeter fibroid, 30-year-old, incidentally found. It's not recommended to follow up on that, especially if there's no symptoms. I mean, it's just a finding. Most patients will have them. We also know that 3 to 7% of fibroids that are asymptomatic, like these little small ones that we just find, they tend to regress. Most, like 3 or 7% tend to regress over 3 years, especially if they're small. They just reabsorb or dissolve. That's usually going to be for the ones that are less than like 2 centimeters or less. Bigger ones won't go anywhere. They'll probably stay there for forever. Maybe in menopause they shrink a little bit, but they won't go away. So evaluation, history and physical, pelvic exam, these are always things that are helpful just to get an idea. The main thing that we're looking for when we do history is, like I mentioned earlier, the goals, what the bleeding pattern is, that kind of stuff. But in physical examination, before having any imaging or anything like that, if you just suspect, okay, let's just see if there's fibroids, just palpating the abdomen. If there's a big fibroid, usually you can just palpating the abdomen without doing a pelvic, you can feel if the patient's not overly large, you can feel this tumoration, and usually they're mobile, and you can put your fingers like this on the abdomen and feel it. So that by itself already gives you an answer. Of course, you want imaging to corroborate, but it starts setting you in the right track. And of course, a pelvic exam can give you a little bit more sensitivity as far as feeling the size of the uterus. There's been a lot of studies that look at how good our physicians, OBGYNs included, in detecting subtle things on pelvic examination. And what we've found is that sensitivity is very limited, especially as the population increases in size. So if you suspect something, but your physical exam does not corroborate fibroids, don't rule it out. I mean, imaging is so readily accessible. That's probably what you would want to do. And the first step in imaging, the first line would be an ultrasound. Just if you suspect based on symptoms and whatnot, an ultrasound is easy, low-risk procedure that can be done, and it's very, very sensitive. I would almost venture to say it's 100% sensitive to detect a tumor in the uterus, because we can see the entire uterus, and if there's a tumoration there, you'll just see it. It's just there. And that can give you a good idea of how many fibroids there are, like approximate about size and location, if they're inside, outside of the uterus, etc. Other tests that we do, and this is more granular once you're trying to figure out how you're going to approach things. Sometimes we do what we call an SIS, or saline infusion sonogram, which basically helps us to differentiate between those submucosal fibroids that we were talking about earlier, the type 0, type 1, and type 2. See how much of the fibroid is inside of the cavity, because if a fibroid is mainly inside of the uterine cavity and the endometrial cavity inside, one of the options that we can offer that it's very easy to do and is very effective is just a hysteroscopic resection. That's just going in vaginally and putting a little camera through the natural orifice of the cervix and using instruments to resect the fibroid that way. No incisions or anything. Quick procedure, very quick recovery. But again, that's only an option when the fibroids are, the majority of them, more than 50%, are pushed into the endometrial cavity. Otherwise, we can't extract them. So that test allows us to figure that out. MRI is very helpful for a variety of reasons. Number one, it is way more accurate than an ultrasound in terms of exactly what the relationship between the fibroid and the endometrial cavity and the myometrium is. So like if we're planning to do laparoscopic or open myomectomy, like where we're going to cut into the uterus to extract the fibroid that way, it allows us to know exactly where to make an incision, to plan where to cut. Especially nowadays, where the majority of surgery we're doing robotically, we can't feel we can't put our hands, like when we do open surgery, we get our hands and we can feel where the fibroids are. Well, when we do robotic surgery, we can't really feel anything. It's just working through the robot. So having an MRI in advance allows us to make sure that we know which fibroids are there and where to target and where to make the incisions. Also, the question, like we were mentioning earlier, not missing a malignancy. Well, what can you do to not miss a malignancy? And unfortunately, we don't really have a lot of good tests to differentiate a fibroid from a leiomyosarcoma or everything in between. They look very similar on imaging. Now, out of all imaging modalities, the one thing that can look a little bit different is an MRI. There is some criteria that radiologists can utilize to maybe make some differentiation. Some large case series, or not case series, actually systemic reviews have, pool things and say like sensitivity can be like around 80, 90% to differentiate cancer from like leiomyosarcoma from a fibroid, but it has to do a lot with who the radiologist or who's reading the images. And if they're actually looking for that, of course, a lot of these studies are done in specialized centers where they're specifically looking for it. So, something to keep in mind. But overall, MRI will be the most sensitive. We also, the role of an endometrial biopsy is important. Now, we don't biopsy fibroids. That's important to clarify. There, you wonder why, right? And the idea is that if you biopsy a fibroid, you might be spreading tissue, or you might cause bleeding or whatnot. But it's not common to do like a true cut or something like we do with the liver or the kidneys. We don't do that for fibroids. So an endometrial biopsy is not cutting into the fibroid. All that is suctioning cells from the inside of the uterus to see if there's any shedding of sarcoma cells, which happens in about 50% of the time when there's a sarcoma. But again, sensitivity is not great. So those are the two tools that we have to differentiate cancer from non-cancer. Again, that's one of the biggest conundrums. Luckily, cancer is rare. By cancer, I mean smooth muscle cancer, not endometrial cancer. I mean, that's completely different. But yeah, those are the two tools that we have for this. And moving on to what are the options for patients? Somebody comes and they have fibroids and they have symptoms. What is the gamut or the spectrum of things that we can offer? And again, all of this will be guided based on the goals, like we discussed earlier. But essentially, we have medical management and then we have procedures. For medical management, here are the options that we can use for for patients, especially if you're managing bleeding symptoms, which are that's the most common symptom. And I just kind of like arrange these from least effective to most effective. You can always just do progestin-only contraceptives or combined contraceptives to try to help reduce bleeding symptoms. Depo-provera is an option. Tranexamic acid is an option, but this mainly works for patients that have very heavy but cyclical predictable periods. Tranexamic acid, we try to limit it to only use it 5 days a month because again, it can cause some renal issues if you use it every day or whatnot. So again, the candidates for this would be patients that only have 7 days out of the month, 10 days out of the month, really heavy bleeding, it's predictable, and that's it. We have them take it for 5 days at the beginning of their cycle, and sometimes that helps mitigate some of the symptoms. Not an option for patients that are bleeding every day. An IUD, hormone IUD, like a levonorgestrel IUD, like a Mirena, that's a great option. I mean, works great to help with bleeding. However, when there's fibroids, studies have shown that there's a way higher expulsion rate, about 11%. Again, this depends on the location of the fibroids, right? If you have like a fibroid that's mainly outside of like a subserosal one that's not that big, it's probably not going to affect, the rate of expulsion. But if you have a very, very large fibroid that's distorting the endometrial cavity, then yes, there's going to be a way higher rate of expulsion. And why it gets expelled, again, when we do these studies, they just pool everybody in there. So the population might be a little bit heterogeneous, but most of these IUDs are probably not placed in the right spot to begin with. It's hard to place it at the fundus when the endometrial cavity is completely distorted. So they probably end up in the lower uterine segment and when they're being placed and then they get expelled. It's an option though, but counseling the patients that it can be expelled. High risk of it. GnRH analogs are another class of medications that we've been using more now that we have an oral form available. In the past, we've had what we call Depo-Lupron, which is a GnRH agonist. That's an injectable medication. There's a version that we give every month and a version that we give every 3 months. And that one's been around forever. But now, over the last 5-7 years, we have these an oral version of a GnRH antagonist. Oralisa and Mefembree are the main ones that are utilizing. And they're Oralisa specifically is FDA approved to treat normal uterine bleeding based on fibroids. For fibroids, we usually have to use a pretty high dose, like 300 BID, 300 milligrams BID. But it's very effective. It works great to stop bleeding. As you can see there, like 87.9%. That's from that randomized control trial that was used to obtain FDA approval. But it does work well, and in our experience, it works well. The caveat with GnRH analogs is you can't be on them forever. The max that we usually recommend for being on these medications is about 2 years, mainly due to side effects from loss of bone mass density. Basically, they're putting the body into menopause essentially while you're on them. And also the side effects tend to be pretty significant as far as like hot flashes and such. Sometimes we do add back therapy to mitigate some of those side effects. We can add like estradiol and norethindrone to take daily, along with the with the Orilissa. But at the end of the day, it's not a permanent fix. And when you stop these medications, let's just say you put somebody on this, they're great, the fibroids even shrunk a little bit. The moment you stop it, everything goes back to what it was before. But it's a great option if you want to give our patients trying to decide what to do long term. But in the meantime, they need something to address their bleeding. It's a great option. It doesn't carry the whole thrombotic risk that birth control pills have. And it's very effective, more effective than all the other ones. And also, it's a great option when we already know we're going to do surgery on somebody, but the surgery is not for another 2-3 months and their hemoglobin is 5 or 6. Well, we can put people on this to kind of like stop the bleeding and hopefully get that hemoglobin up a little bit better, so recovery from surgery is improved. So these are all medical options that anybody can prescribe. So it's important to know that they're on the armamentarium. And then procedures, again, there's a wide range here. We have, and these are not in any particular order, but we have uterine artery embolization, and that's a procedure that's done by interventional radiology. It has a rate of reintervention at 5 years of 19 to 38%. That means that in 5 years, about 40% of the patients will have another surgery, whether it's another embolization or a myomectomy or a hysterectomy or something. One thing to keep in mind with uterine artery embolizations, it seems like a very, low risk. You just go and embolize the uterine arteries and outpatient, and that's great, but it's not. Most of the time, whenever we do these, especially if people have large fibroids, we literally end up having to keep them in the hospital for 4 days to a week to manage their pain. This is a very painful. The procedure itself is not painful, but as the blood supply is cut off to the fibroids, they start releasing prostaglandins like crazy, all these inflammatory markers and whatnot, and patients are in pretty severe pain. We have to keep people on a PCA for a few days in the hospital usually for these. So something to keep in mind with that one. High intensity frequency ultrasound. We don't really do that much here in the US, but it exists. Very high rate of intervention. It's not a very effective procedure. ACESA or fibroid RF embolization is gaining more popularity. It's been around for about 7-8 years already. And essentially all that is we insert, and we start like a laparoscopic procedure, visualize the fibroids, and then we stab the fibroid with a little metal rod that has little electrical wires in it. And we essentially fry or cook the fibroid from the inside to burn it using RF energy. So everything stays in place. We don't extract anything. We just kind of like poke the fibroid a bunch of times and burn it. Depending on the size, we have to maybe do multiple, pokes in order to burn the entire part of the fiber. But anyway, it has we only have 3-year data for this procedure because it's kind of recent. But it looks like it's, rate of intervention is pretty low. One of my biggest issues, I guess, with these things, I guess, is the lack of histology. You're going in there, you're burning a tumor, it's a neoplasm, you're burning it, but you never had any tissue diagnosis or proof that it's not something different. And because cancer is so rare, I mean, these haven't really bubbled up to the surface, but I wouldn't be surprised if in 5-7 years, there'll be this huge class action or something again, for, based on people that had sarcomas that were not diagnosed and were burned with these. And then, 3 years later or 2 years later, they have metastatic disease all over the body. I mean, I think that I predict that is probably something that will end up happening, but it will take time because, again, luckily, cancer is very, very rare. Myomectomy is basically just cutting into the uterus and extracting the fibroid. Simple as that. Like I mentioned earlier, sometimes we can do it hysteroscopically, so through the vagina, but that's only if the fibroid is in the cavity. Otherwise, we do it laparoscopically or open, cut the uterus, shell the fibroid out, and then stitch it back up. And then, of course, a hysterectomy is always an option that has no intervention because we just result, there's no risk for fibroids coming back or the symptoms to persist if that is done. That was for bleeding. I mean, both symptoms, all very similar. The procedures that can shrink the fibroids are the GnRH analogs, shrink them a little bit. The embolization can shrink the fibroid a little bit. RF ablation significantly shrinks the fibroid because you burn it, so it stays there, but it kind of like over time turns into this kind of like ball of mush, so to speak, just mushy tissue. You can see it on ultrasound over time because it's still there, but it definitely reduces there's a decrease in volume. And of course, excisional surgery, well, you're removing the tumor itself, so that will reduce the volume. One thing, just if you're reading literature and if you're reading studies reps come to your clinic and they're talking about reduction in volume, always keep in mind, this is something that a lot of OBGYNs fall, I don't want to say victim to this, but you talk about reduction in volume. Volume and diameter are not the same thing. So for example, if you have a 10 centimeter fibroid and you only reduce it to 9 centimeters, for me, in my book, that is not significant because 9 centimeter is still a pretty large mass, but the volume is pretty large if you think about how much volume was reduced from 10 centimeters to 9 centimeters. And that's just because of the, cubical nature of the formula to calculate the volume of a sphere. So just keep that in mind. Volume and diameter are not equal. Something just before we move on to the cases, I just wanted to say a little bit on this infertility and pregnancy outcome, because sometimes that's another big reason that people refer, patients with fibroids to us. They can't get pregnant. They get an ultrasound and there's a 2 centimeter fibroid somewhere, and okay, that's the cause. That's why they're not getting pregnant. Well, and then the other thing is when people are having miscarriages, or if they have a fibroid and they want to get pregnant, but they're scared because they're afraid they're going to have a miscarriage. So regarding miscarriages, it used to be thought, I'm talking about 10 years ago, even probably less than that. I mean, this study was published in 2017, but it used to be thought that fibroids were a risk factor for first trimester miscarriages, for losing the pregnancy. In 2017, there was this huge meta-analysis that included over 20,000 pregnancies. And based on that, after adjusting for confounding factors that in the past might not have been adjusted for, it was found that fibroids do not increase the risk of miscarriage. So we know that based on this large trial, and that's pretty good quality evidence. So we don't usually counsel patients that miscarriages, they're at high risk for that once they're pregnant, Now, infertility, not being able to get pregnant, well, again, how we talked about size and location, it all has to do with that. Clearly, if the fibroid is large enough that it's obstructing or kinking the fallopian tubes, well, that might impede, transport of the sperm and the egg and to make that connection. So from that standpoint, yes, it's going to cause infertility, but that would be only if you have a fibroid large enough to distort that portion of the uterus. So it has to be in a very specific location and of a certain size in order to do that, in order to result in that. Also, endometrial distortion is another thing that might prevent implantation. If the endometrial cavity is completely messed up and it's full of fibroids, well, the pregnancy will never be able to land and grow. There's some talk as well as maybe at a molecular level, when there's fibroids inside of the cavity, there might be what we call crosstalk, where the presence of the fibroids alter the normal endometrial cells. Again, at a molecular level, there are some alterations that occur, and that might impair their receptivity. So, fibroids can certainly cause infertility in some specific occasions, but the majority of times they won't. We usually attribute, of all patients that have infertility, we usually end up blaming the fibroids for, 1%, 2% of cases. So it's not a common cause of infertility, basically. So the cases that I'm going to present, I wanted to give us, I know it's like a lot of information kind of, but just to give a little bit of background to understand kind of like the rationale of these next peculiar cases. And this is, again, this is because there's a huge variation of how patients present, and usually these can be like clinical conundrums of what to do with how to care for these patients. So the first case, this is a 65-year-old postmenopausal patient who presented as a referral secondary to an incidental finding of a 17 centimeter uterine mass on a CT scan. The CT scan was done because the patient had severe pelvic pain and there was suspicion for an incarcerated ventral hernia, which she actually did have. She had an incarcerated ventral hernia containing small intestines. So during that event, she was taken back to the operating room with general surgery, who repaired, reduced the hernia and repaired it primarily. However, 2 months later, there was recurrence of the hernia. Patient started seeing a large a bulge again in that same area and severe increased pain. So she had another CT scan which confirmed the recurrence, and it was found that, again, she had a 4 centimeter defect in the fascia. In the hernia contained small intestine. Again, the 17 centimeter large mass was located. The patient's history is remarkable for morbid obesity, hypertension, type 2 diabetes, managed with insulin. She was not a very healthy lady. And her main symptom is severe and abdominal pelvic pain. No vaginal bleeding. So what do you do in a situation like this? Well, in this particular case, obviously she has a hernia and you want to attribute it. Okay, that's the problem. I have images here, so I'm gonna run. This is kind of like a sagittal cut of a CT scan, and I'll try to point things out as this moves. So this mass here, that is the mass. It's huge. I mean, here you can see her sacral promontory. Pelvis is down here. The uterus is supposed to be here. This is all occupying the entire abdomen, is her liver. If I go back, you can see here where I'm pointing with the mouse. This is all small intestine that is eviscerated, or outside of the fascia. Tons of loops of small bowel here, so that's a problem. So, and then you have this. So what to do? So first of all, who will take care of this patient? So clearly you have somebody whose quality of life is significantly impaired. This patient was in severe pain, basically could almost not walk. I mean, it was completely destroying her quality of life. Now, there probably is a combining factor of course, there's this mass that is in their abdomen, and it's significantly heavy and it's pulling and everything, but at the same time, you have this hernia that's there. Well, because of the mass, general surgery in this particular case would refuse to see the patient until the fibroid was taken care of, because the opinion was that if the hernia is repaired with the fibroid still in place, the pressure of the mass will push it back again, and it's going to fail again and again and again and again. So you have that. On the other hand, you have the situation where, well, as you saw in the images, the small intestine is in the way of performing a hysterectomy. You have to fix the hernia to perform a hysterectomy. So, again, one of those challenging cases that it's hard to find, care for this patient. So she was referred to us. And one of the things that we, based on what we were discussing earlier, is medical management an option for her? Well, clearly there is no, I know we talked a little bit about medications and things that can reduce the bulk of a fibroid, but as we were mentioning earlier, something this large, there is no treatment that is going to reduce it enough to be able to, make it non-significant just because of the sheer size of it. So, medical management, probably not an option. Same thing with a procedure like an embolization. Probably not the best idea to do in a 60-something-year-old that you have this large mass, and do something where you don't get a tissue diagnosis and start causing necrosis. So that is not an option. But then a surgery, like large surgery, doing a hysterectomy is not like repairing a hernia. It's a big operation, especially in in a patient with a tumor this size. Is that even a possibility considering her comorbidities? So obviously the diabetes is something that needs to be addressed. Doing major surgery if the sugars are not well controlled can, again, increases the risk of problems down the line significantly. So usually we look for glucose levels to be under 200 consistently in order to, do these kind of surgeries. And finally, does she have cancer? So to answer that last question, as we discussed earlier, well, what are the best tools that we have to figure out if somebody has cancer or not cancer? And by the way, this in this patient, we only had those 2 CT scans, no other imaging available, just the CT scan, the initial one when the hernia was first repaired, and a few months later when she had the recurrence of the hernia. There was no difference in the size of the fibroid between those two. Well, in this particular case, one of the things that this was not an MRI, what I showed you was a CT scan. So not great to evaluate the internal architecture of the mass, but the fact that it has calcifications, that by itself is a pretty clear indicator that that fibroid has been there for a while. It takes a while to become calcified, which is highly suggestive of a benign process. The other thing that could have been done is an endometrial biopsy, like what I mentioned earlier, to look for cells that were shed into the endometrial cavity. But because of the calcifications and the fact that this didn't change over 4 months, we just opted to move forward with the operation. So this patient in particular underwent outpatient robotically assisted laparoscopic hysterectomy with primary hernia repair. Now, we didn't put mesh in because whenever we do a hysterectomy, technically is what we consider a clean contaminated surgery since the vaginal cavity is breached and there's no real way to sterilize that. There's always a concern that if we put mesh, it will become seeded with bacteria from the vagina. And if a mesh gets infected, I mean, that's a huge issue. So we usually tend to repair hernias primarily. Here you can see a picture of just the size of it laparoscopically, and as we are reducing it and pulling out all those loops of small intestines. And there's a picture of just what the uterus looked like. Clearly there's no discernible anatomy. It's just this huge mass. So final pathology was benign. Fibroid with degenerative changes. She did have actually multiple hyperplastic endometrial polyps, but no atypia. So that's good. And the specimen itself weighed over 2,500 grams. So pretty large. And she's doing well. 3 months after for her follow-up, her pain obviously was fully resolved. There was no recurrence of the hernia. The idea or the plan was if the hernia was to recur, then she can just have mesh. Was general surgery, we would just send her there. We wouldn't do that one. So that was the plan for her. So she did well. But again, this case exemplifies a combination of also having the patient's primary care physician help with optimization of their diabetes and that kind of thing to maximize outcomes. The next case, it's on the other end of the spectrum. This is a younger patient, 27-year-old, gravida 0, with progressively worsening pelvic pain, bloating, dysmenorrhea, and also very heavy menstrual flow. This patient in particular had a very active lifestyle. She actually was a bodybuilder, like she did like photo shoots and everything. So it was, cosmesis very important to her, but also, fast recovery very important for her as well. No previous surgical history. And she had been treated by her primary OBGYN with a combination of Nexplanon and OCPs. So her OBGYN put her on both things because the implant by itself, which I know I didn't mention that earlier because it's not really considered a treatment for fibroids, but for bleeding, sometimes the implant, technically the Nexplanon implant can help with bleeding. But since that wasn't helping, she was also placed on OCPs at the same time. But the symptoms, even though it helped a little bit, not enough to be satisfactory. And of course, this patient wished to retain fertility. Like we said earlier, she had imaging. And this is her ultrasound. This is an ultrasound, a classic fibroid. You can see here the limits, very clear border, no question about that. This here in the back, that's the uterus, the myometrium. So very well defined, measuring about 6 centimeters. And in her particular case, because we, talked about things that she was referred eventually to my clinic, and we had talked about myomectomy, removing just the fibroid. We did get an MRI as for surgical planning, like I was discussing, and I'm going to show you that here. Now, this is a axial view. So like I said, the patient was laying down. And here you can start seeing this here is the fibroid. This black spot here, that's the endometrial cavity. So here, for example, you can see how the endometrial cavity is distorted. The fibroid is pushing the endometrial cavity towards the midline, right there. That's what I'm pointing at the endometrial cavity. And then you can see the fibroid. So again, I want to point out a few things. You have this mass here, which is what we saw in ultrasound. But then you see all these other little things here that we didn't see on ultrasound. All these little pieces, fragments here that look like fibroid as well. Again, when we look at the signs that we, when we're evaluating for cancer and what kind of stuff, we're looking for necrosis, and there's no sign of that on these images. No lymphadenopathy or anything like that. But what we do notice is that the fibroid is pretty low on the uterus. It's pushing this lateral, and it's very close to the ureters and the uterine arteries. So because of that, you think about, well, what can we offer to this? She already tried medical management. It didn't work. It's causing also pain in both, again, the location, because of the location, it's kind of like pressing where on a narrow portion of the pelvis. So it's probably pressing on the nerves. And this is why probably the pain symptoms are very prominent in this particular patient. Procedures that we were talking about earlier, like embolization or where we stick it and fry it, probably not great procedures, just considering how this looks in the location. The one where we getting the uterine artery on that side might be challenging just because it's kind of pressing on it. And also the burning it with like that Acessa procedure where we stick it with a needle and burn it. Well, it would be so close to the ureters that there could be a risk of heat spread or something. So things that, deter us from planning to do that. But again, 26-year-old, not really suspecting, cancer or anything like that, especially how it looks like and just based on her age. So in her, is further medical management an option? The one thing that she could potentially have tried would be GnRH analog. She did not want to do that. Again, this is just a temporary fix. It's not going to permanently solve the problem. So she opted against that. We talked about how the location of the fibroid can alter treatment decisions. And does she desire a future pregnancy, which she did? Well, that alters treatment selection as well. One thing to keep in mind is out of all the procedures that are actually procedures, like burning the fibroid, embolization, etc., the only one where we have good data to know that future pregnancy is fine is a myomectomy. So removing the fibroid and then stitching the uterus back up. There has been case series of successful pregnancies after a uterine artery embolization and after the Acessa procedure where the fibroid is burned. However, we don't have enough data to really come out and say, oh yeah, this is FDA approved if you're looking for fertility. So technically, if somebody wants to have babies, technically the correct thing to do is a myomectomy, which is what we ended up doing in this patient. The reason she ended up in my clinic in particular is because, the location of the fibroid, there was concern that it was going to be difficult to reconstruct the uterus after it was excised. So that's why this patient was sent to my clinic specifically. And is imaging suspicious for cancer? Well, no, the answer is no. There was no suspicion of that. So here there's just pictures of the surgery. The top one is as the fibroid is being excised. We also went through for those little fragments that were left behind. We kind of kept looking for those and kept extracting those as well to send all those off to pathology. And then the bottom is just how it looks like after the reconstruction. So the final, this patient also had endometriosis, by the way. She had pelvic pain. So we always look for endometriosis concomitantly because people can have both conditions and they both contribute towards pain. And she did have it. So we resected that. But anyway, she had endometriosis, but the tumor ended up being what we call an IMT, which is a pretty aggressive form of cancer. So at that point, you have a 26-year-old with uterus still in place, this tumor that was resected, but we saw on the MRI that there was multiple small fragments. So who knows if there's microscopic fragments that we didn't see that are still there just because of how it looked. So it's kind of difficult to know what to do in that situation. Ultimately, the patient opted to proceed with surveillance. She didn't receive chemo or anything. This was presented at tumor board. She did have a CT of the chest, abdomen, and pelvis 3 months after the surgery to make sure there was no metastatic disease or lymphadenopathy or something that developed after doing this procedure, but there wasn't any. But this goes to show, what if we would have burnt it? What if we would have gone ahead and stuck the needle and done that, or do an embolization? Well, that would have been a problem, right? We wouldn't have had a diagnosis, and the effect of burning a cancer, that is not great. That actually can promote sometimes spread. So yeah, it just goes to show, there's a wide spectrum of things. You always have to keep your, you can stay on your toes of how these things, can be all kinds of, there's a huge spectrum of what these things can be. So in conclusion, in general, always keep patient goals in mind when making treatment decisions like we discussed earlier. Although it's rare, like we mentioned, for fibroids to be cancer, it's still something that can happen. We just saw, so it's something to keep in mind. And the treatment of these things is always multidisciplinary. Primary care providers play a crucial role in optimizing patients. If somebody decides to do surgery and they have diabetes or other issues, this, for recovery purposes, it plays a big role in how patients do afterwards. So it's a team approach to achieve the best outcomes possible. So yeah, that's all I got. I'm happy to take any questions.
Thanks a lot. I thought that was a great presentation. I think you really took something, and most of us really only get surface level instruction on uterine fibroids. So taking it down another level, but still keeping it where it was digestible, I think was really, really, really well received. So I don't see any questions in our Q&A, but I did write down something that I wanted to ask you about. So it sounds like from what you're saying that you would agree with this statement, but I don't want to put words in your mouth. So it sounds like the radio frequency treatment you see almost now sort of like we have gone with the way of cryo treatment during colposcopy or morcellation during a hysterectomy, where because it destroys the tissue that you're actually trying to observe, then you see it sort of falling out of favor because then there could have been something hiding there that we didn't know about.
Yeah, and we're not there yet. Right now, as a matter of fact, it's gaining popularity because it's a very simple procedure to do, the RF ablation. And yeah, and patients do better as far as like bleeding symptoms and whatnot. So it's a low-hanging fruit and again, very simple, very low risk procedure from that standpoint. But as time goes by and more patients have those procedures, there's going to be invariably cancerous sarcomas that are burnt. It's going to happen. There's no way it's not going to happen because, again, there's no way to, like we just saw in that case, there's no way to accurately diagnose it beforehand. And when it does happen, depending on how those patients do and whatnot, it might take a while, but eventually it might, lead to similar situations like with the power morcellators and such, just because of the lack of histology. That being said, you don't have to, how does that phrase go? Throw the baby out with the bathwater or something. There might be a middle ground where we might find a way of actually biopsying during the same procedure when you're doing RF ablation, maybe using a true cut or something to biopsy the inside of the fibroid and send that to have some kind of histologic specimen. And then you burn it. But then, of course, if you find the sarcoma, then you go back and do a hysterectomy. So that might be a way to mitigate or mediate that. It's not standard of care to do that right now. And I'm not aware of any studies, looking at that particular approach, but that might be something to be, attempted. Again, it goes to, well, is biopsying one little piece of this huge 8-centimeter tumor sensitive enough to make sure there's not sarcoma elsewhere? It's just, you don't know, right? We don't know. We don't have the answer to that question. So yeah, we'll have to see how things go. But I'm not saying it is a procedure that obviously helps a lot of people. It's a very simple procedure. Like I said, a lot of providers love this operation because it's simple. I mean, I'll tell you, it reimburses well. Just a lot of these new procedures, they have high RVU rates. So it's gaining popularity. And patients, the majority of patients obviously do well, right? So it's good. Personally, I don't, by the time patients get to me, it's usually not, they're not candidates for it usually by the time they get to my clinic. So I'm not doing the ablations that much. And I think my particular perception might be a little bit more biased just based on the population I see. So I just kind of makes me cringe a little bit to not have a tumor, a neoplasm, and burn it without having a tissue diagnosis, So, but again, I don't think it's wrong to do this procedure. It's there. It might happen, like what you were just mentioning, as time goes by. It might be 5 years, 7 years, 10 years, but I think there will be a few cases that bubble up to the surface and get reported. And then, we'll have that conversation at that time of what to do. But as of now, it's available. It's definitely an option. It is standard of care. It's endorsed by the American College of OBGYN. So that exists.
Well, thank you. I appreciate it.